Hi, I'm David Higdon. I'm the patient care manager of the emergency department at Ocean Springs Hospital. I'll give you a quick tour, okay? The 50-cent tour. Come this way. Small lobby area here where patients would approach for to be seen and request to be seen by the doctor. We have two triage rooms here. You've actually got a triage nurse that's sitting there waiting for the next patient as we speak. We have badge access only here for security purposes. We're very cognizant of patient and staff safety. So can't just let anybody and everybody wander through. We have to monitor that pretty closely. This first little hallway is a minor care area. So we have 4 rooms that are where patients are placed that have a lower acuity kind of problem. That's something that would be an easy in the doctor's office, type of event. Usually have a nurse practitioner or a PA, one of those mid-level physician assistant kind of roles that can see those patients. Currently, it's only open from noon to 9 every day, 7 days a week. So this area is closed right now. It's before 12 a.m. Come on down this way. This is one of our typical emergency department treatment rooms. You can see that there's nothing really special about it, but all our rooms have cardiac monitoring equipment in it. As far as other vital signs, we have televisions and little artwork, make it a little bit less institutional. A little wood-looking floor there, so it's not quite as intimidating for you guys when you have to come in. This is a shot of the central nurses station. So all the nurses and technicians, clerks, physicians, everybody works out of this space. So we have one central location. We can communicate well, and patient care flows out from this central location into rooms that are all around. We'll come on down this way to the trauma area. So we have 2 main entrances to the department. Where we first came in was the walk-in entrance where our lobby is located. That's the way the vast majority of patients arrive. But we also have an ambulance entrance back on this end of the department so that ambulances can pull up under the canopy and offload and come directly into a major treatment room. So we would be handling major traumas, strokes, cardiac events, anything of a more intense nature that requires a lot more intensive care and more staff to help take care of them. So you can see this is a nice big room, bigger than the other room that you saw, so that we can get a lot of personnel around the patient as we need to. So in the emergency room, it's not just doctors and nurses. Like I said, we have technicians, clerks. Other departments have to work here as well. We have respiratory therapists, radiology technicians that are doing the x-rays right here in the room. Lots of other departments have to work with the ER. It's all very much a team sport, so that we can take care of whatever the patient needs. This is one of our major treatment rooms or trauma rooms. So each one of these has a crash cart with emergency drugs on it. It's immediately at hand, so we can administer it to the patient right away, whatever they need. They all have defibrillators, so you see on TV how they have to jumpstart you. That's kind of what that is. This is a backup. It's called an Omnicell. It's a backup vending. It's like a vending machine for drugs. So they're emergency first-line drugs that are on our blue crash carts. These are backup drugs, so that if the nurse needs more drugs than the cart will contain, we've got that right at hand, so the nurse doesn't have to leave the room. You'll see a lot more stuff, a lot more supplies in these big rooms with that same purpose in mind, so the nurse doesn't have to leave the room to secure more supplies to take care of the patient. We try to anticipate those things that would be needed the most often and have those here at hand for the nurse. Big TV on the wall is actually a monitor screen for the small bedside. It's the same. Notice it's the same information. That is so that when there are a lot of people around the patient, everybody in the room can see what's going on with the patient's vital signs, heart rate, blood pressure, cardiac monitor, all that type of information that would be important to know. We have certain boxes you'll see in the corner here that are loaded with supplies that are needed for central line insertion. So sometimes we have a patient that needs a big line inserted into a central vein. rather than a peripheral vein. So we have all of the types of equipment, supplies that we would need for that type of situation. You just pop the top off the box, and everything you need is right here, so the nurse doesn't have to gather various things. Saves time, which in turn saves lives. That in a nutshell is really the basics of the ER. The ER is a little bit different than everything else. A lot of times you're seeing people on the very worst day of their lives. So the emergency nurses and physicians and personnel can really impact not only the patients but their families, and in a very positive way.
Hi, I'm Melissa. I'm an ICU nurse. Welcome to Critical Care. This is one of our typical critical care rooms. This is the basic setup. You can see the equipment that we have here. We have a monitor for the readings for our patients, blood pressure, heart rate, etc. We have infusion pumps. We have special beds, and we have oxygen setup and O2 delivery and air delivery. We also have suction equipment. This is a basic room. A lot of times, depending on the patient and how critical they are, this room could be full of equipment and full of pumps. And it can be quite challenging but interesting at the same time. Some of the type of patients that we typically get are trauma patients. And those patients would be the type of patients that have motor vehicle accidents, have four-wheeler accidents, and sometimes just being in the wrong place at the wrong time. And we try to help those people. We take care of them and we try to get them back to the way they want to be, at the best they can be. Some other type of patients that we may take care of are people that have diseases that they've been diagnosed with, or some type of organ injury. One would be like COPD, obstructive pulmonary disease. This is a diagnosis that the doctors give a patient when they have a history of cigarette smoking. And sometimes those people have a hard time during different times of the year, because they have what we call exacerbations. They may get a little bit sicker on top of being sick, so they may end up in our ICU under our care. And we kind of help them get a little bit better to get back on their feet and to be at what we call their baseline. So, what does it take for a patient to get back to their baseline? It takes a team. We have a team of people that come together to help these patients. They call it an interdisciplinary team. You have a physician or physicians, you have nurses, you have respiratory therapists, you have occupational therapists, you have physical therapists, you have dietitians, and then we have ancillary workers, people that help clean our rooms, keep our rooms clean for our patients. We have maintenance people that help the hospital stay functioning as a whole. And it's important. Each little intricate piece of that is important for the patient. Being a critical care nurse is intense, it's challenging, it's rewarding. And just to be able to see a patient when they're not doing so well, they don't feel so well, and you're helping them, and they do get better, and you see them get up out of that ICU bed and take those first steps around the unit, is one of the most incredible feelings. And really, as a whole, the whole unit celebrates when that happens. So at the end of the day, it's all about helping people.
My name is Tracy O'Flynn. I work on the progressive coronary unit, and I mostly work here in the intermediate care unit. This is where we get patients post-heart cath, the cardiac catheterization. We usually bring them in here and we monitor them for a few hours. Some of the patients who come in here have arterial lines, and we'll hook them up to these monitors right here, and we'll watch the patient. We'll see what they're doing on the monitor to watch their pressures. We'll pull the arterial line, stabilize the patient. Once they're stabilized, we'll go to the telemetry room, which I'll show you in a few minutes, and get a monitor, and then bring them to their regular patient care room. I've got all kinds of equipment over here that I can use to, like an ACT machine, to draw activated clotting time before I pull the line. We have 5 bays in here where we can monitor 5 patients. It is basically a 1-to-1 unit. They really don't want us taking any more than 2 to 3 patients at a time in here for any one nurse. So sometimes they do have a couple people working in here. Right now, I've got a patient that I'm monitoring just for a few hours. He had a heart cath and he got a sealing device. He did not get it fixed, so he'll be able to go home later. We keep him here because of bleeding. They give patients a lot of blood thinners during a heart catheterization, so we have to watch them, make sure they don't have any bleeding issues. Believe it or not, some people do have a lot of bleeding issues post-coronary catheterization. This is also the progressive coronary unit here. We take care of patients with heart problems, patients who've had open heart surgery. This is where they come to recover. We hold 12 beds here, and most of the time they're always full. This is where your congestive heart failure patients go, hypertensive, patients who have had open heart surgery, anything like that. Also the post-coronary cath patients, they'll come to this floor. This is the nurses' station, and these are some of our nurses, Caitlin and Dawn, working really hard. This is the monitor room. This is Sabrina, one of our monitor techs, and she monitors her along with another monitor tech. They monitor everybody on the telemetry monitor here in the hospital. Really busy, really important job. If anything happens with any patient with an abnormal heart rhythm, or if they come off the monitor for any reason, she contacts the floor and finds out what's going on with them. These are the monitors that we use, and they are portable. They hook to the patients. They can walk around with them. They can put the little box in their pocket if they want to. Pretty neat little device. As you can see, it gets pretty busy in here.
Hi, I'm Tammy Hyatt. I'm the nurse manager of CRC, Comprehensive Rehab Center. On CRC, we take care of a multitude of diagnoses, patients that are wanting to rehab so they can go back to their former life. We take care of, the nurses on CRC takes care of everything from patients with diabetes to kidney diseases that may be on dialysis. We take care of patients with amputations. We take care of patients with PEG tubes. We take care of patients on IV antibiotics. We do a lot of education to teach our patients and their families how to take care of what's going on with them, so if they need to go home, when they're ready to go home, they can go home and their needs will be met.
My name is Miranda Hurst. I'm a certified occupational therapy assistant here at the Comprehensive Rehab Center on the 4th floor at Singing River Hospital. I'm here to tell you a little bit today about occupational therapy. Physical therapy will be talking to you at some point, and everybody thinks occupational therapy is physical therapy. They do the walking and the distance and the quality of the steps. We care about those things too, but with occupational therapy, activities of daily living, self-care, that's our end game. How are people getting up and down and around to get to the bathroom, to get dressed every day? Is their balance good enough to put their pants on? Can they reach down to put their socks on? Are they safe in a shower? Independence for the return home. That's what we are focusing on. I have a couple things here that I can show you that we do here in our gym, and then I'll talk to you a little bit more. We really care about, people always say occupational therapy, upper arm strength. That is very true. When your legs aren't working very well, you need your arms to help compensate. We do work on those things. We also work on your shoulder. We work on fine motor skills. We work on gross Hand strength, those are all things to help you button your clothes, to lace your shoes, to pull up your pants. Can you grasp well enough to grab your brush? Can you reach up here to grab your brush? Can you hold onto a walker to get where you're going to go? Can you grab onto the bar to get onto your toilet? Can you push yourself up to get out the toilet or into the shower? Those are all things that we work on. A couple things that we have here in the gym. We have an arm bike over here that will help you with your activity tolerance and your endurance. You just kind of spin, where we can adjust the resistance and things like that. The longer you go, the more activity tolerance and energy you have. We have these little ADL books. This one's a little beat up. Helps you with things like snaps, buckles, buttons, lacing, tying shoes, things like that. Containers, can you twist? Can you open? Are you going to be able to open these things to do the shampoo? If you can't, this is where we start working on adaptive equipment, things to make those things easier for you. Hand putty, everybody's used it, pulling things out. It's kind of tough. It's not as easy as it looks. It's not Play-Doh. It actually is rough to get out of here when someone's got little hands that don't work the way they used to. We have things like this, where it looks like they're doing some matching, helps with cognition, confusion. Can they pinch? Can they pull Velcro? Can they visually track? Vision is something else we work with. Sometimes we'll work with strokes, people that have had some kind of issues or damage to their eyes. Can they visually find it? Can they look around? Can they focus? Head up, head down, side to side. Things like this look like games, but they all have a purpose. But our real deal up here on this floor is actually taking people into a real shower, scheduling bathing with them, working on their dressing skills every morning with these people, because real life stuff is where it is. This stuff looks like fun and games. It's really hard for certain people, but at the end of the day, the real stuff is what really works. So we try to do as much daily task as we can with our patients. We'll get the shoes in here. We'll have to help them do that or see if they can do it. I'll go in with them in the morning. We get them in the shower room and do dressing with them. So you will see naked people. If you don't like that, OT may not be for you. But it actually pays off, because wouldn't you want someone to help you learn how to bathe if you couldn't get up every day? We do self-feeding sometimes, so we're the ones that are going to take a look at somebody if they can't use their spoon, if their hands are shaking and they cannot bring their cup to their mouth. That's where OT comes in. We're going to make sure that they have something where they have a better grasp, or tools that can hold onto the spoon for them, cups that are a little heavier if you have tremors or with a top. Can't reach your feet, had a hip surgery, or just a really old injury where you couldn't put on your own socks and you really want to do that for yourself. We're going to start breaking out some equipment for that. You're going home, you can't stand up in the tub long enough, your balance is bad, we're going to look at things for the tub. So just basically getting your independence back for your self-care, where you don't have to have someone take care of you as much as if you didn't have a little OT. So strengthening, hands, shoulders, dressing, bathing, we do it all. We do it all. So that's occupational therapy, very rewarding job. Thanks for taking the time to listen. The best part of occupational therapy is watching someone get better. When somebody is very stressed out about the fact that their little husband cannot help them go to the bathroom, and all of a sudden, after a week worth of work, they actually toileted by themselves, and they're thinking, oh my gosh, I never knew I could do this. I thought my granddaughter was going to have to help me forever. I mean, it's their dignity. And so to help somebody regain that is a huge deal. It is the most rewarding part of my job. When I have a husband grab me and hug me because he didn't think his wife could come home, and now he can actually stand her up long enough to help her pull those pants up when at the one point she couldn't even get out of a chair. I mean, how do you not love this job? So that's occupational therapy.
Hello, my name is Wendy Hawkins. I'm a physical therapist at Singing River Rehab up at the Comprehensive Rehabilitation Center. It's an inpatient rehab, mostly strokes and amputations and high-level patients that need a lot of therapy, physical therapy, occupational therapy, speech therapy, and nursing care. We have a physician daily because these patients are difficult, and they need a lot of monitoring in addition to the exercises we provide. They may have a lot of other problems like heart problems or lung problems that need to be monitored while they're exercising. So we come together as a team to help this patient, and we meet on a weekly basis so all of us together can come together and talk about this patient and the family and what they need so we can get them home to resume their life. They can be able to play on the floor with the grandkids. I am a physical therapist, and now it is a doctoral program. There's also physical therapy assistant programs, and I have the best job in the world because I get to make people better and they hardly ever die on me. When family members can't get out of the wheelchair and then you're able to help them where they can get on the floor again and play with their grandkids, you've just changed a life. Not only their life, but also their family's life, the grandkids and their children's lives. Their extended family, you help everybody. So we have lots of tools in our tool bag. We don't just have any one thing that works for one patient. This is called a new step. It's not a bicycle, it's more like a sitting stepper right here. So a patient comes in that has Parkinson's, they tend to become very stiff and not have much movement. So you'll have the reciprocal walking with the steps. You can use the arms or not use the arms, but they'll be twisting when they use the arms for trunk range of motion and to be able to twist. Because when we walk, we move one arm forward at the opposite leg and we twist our trunk. So this simulates walking but in a seated position. This will turn to make it easy to get their access to enter this. And then down here we have resistant levels. So we start out easy and then we go more difficult. The other thing is these arms will come up and say someone is not able to transfer or stand. We can bring them right to it to transfer, or if someone doesn't have legs, they may have a below knee amputation on one leg or on both legs. This is called a transfer bench. So it just basically bridges two surfaces. So the person can move from the wheelchair to this or to even a potty. And we also have a variety of weights from 1/2 pound to 5 pounds. If someone cannot lift the weight of their leg, then they're not going to be able to walk. And if they have their body weight, if I weigh 90 pounds and I'm not going to be able to lift my weight of my leg, I'm not going to be able to support my body weight. So we usually start out with just the weight of the leg, then we can increase by 1/2 pound to 1 pound to 3 pounds to 5 pounds, and we can increase the repetitions to increase their strength. We have different walkers. A lot of times patients will come to us and they may have fractured their hip and they're not able to walk, or they've had a motorcycle accident. So this is the typical walker you will see. Say someone cannot put weight on one leg, they can move it and then hop to it. Now physical therapy will do gait training and making it safe, because a lot of people either want to walk with the walker too far in front of them, which will make the walker go flying and they'll end up on their face, or they may step too far, which may make them end up on their bottom. So, and you want them to walk in the middle of the walker, so there's a good bit of gait training and skill to this. Two other pieces of equipment that we use a lot to restore mobility. One is the stairs, so that way we don't have the safety issues of trying to get patients up and down the stairs and the risk of them falling down a flight of stairs. We have a lower level depth on this side and a higher level that'll be more steep on this side to vary what patients may have at home. And then we can be on either side or in front and back to start helping people be able to negotiate this, because most people do have one step inside their house. Our other critical piece of equipment that we use is the parallel bars. When patients haven't been able to stand in a long time, we can bring the wheelchair right up. They feel very safe. We can have people on either side to block their knees. This will help them stand up. We can move these in for little people and out for bigger people. We can move them high for one hand, low for another hand. Say we have a stroke patient that has a contracted arm, then we can move this higher. This is what's called a gait belt, and this is vital to the field of therapy because most of our patients are sick, or when they stand up they may get dizzy and pass out. This will save us. It will help us hold them up, and if they start to pass out, we can sit them right on our leg till someone can bring us a wheelchair. This is vital to the field of therapy, and it's a very simple tool. And at home we recommend it a lot because we don't want patients to fall at home. This is some pictures of some muscles of the face, and most people think that speech therapy just deals with talking, and it does. It helps with articulation, the volume of speech, but speech therapy is so much more. Say grandma's having difficulty with her cognition, which is their memory and how they process information. They may not realize safety issues as you get older with using the stove. So not only do they do speech, they do memory, a lot of things with the brain and the face. One of the most important things that they do is called swallow therapy for dysphagia. This is a vital stim unit, and depending on where their stroke is and where their weakness is, she will put electrodes at special places to help stimulate these muscles to make them stronger. So a lot of stroke patients, they can't swallow water because it's so thin that when they swallow it, it goes down too quickly and it will choke them. It can go in the lungs, and if they're drinking juice or coffee and it goes in the lungs, it doesn't really mix, and it can cause what's called aspiration pneumonia, and people can die from this. So it's very important that they sit up correctly and that their muscles are able to swallow the food. If they can't maintain their nutrition, either drinking the liquids or eating, then they may have to look at a PEG tube. So sometimes patients can't do therapy if they can't eat or drink. So this is very important to be able to swallow. And think about what you like to do. A lot of people come in here and they just want to walk. Well, if they can't eat and they can't drink, they can't walk. So I'm not a speech therapist to be able to tell you everything that they do, but I know that they're vitally important. This is one of the most used devices in speech therapy.
We look at images to diagnose disease. We look at CAT scans, MRIs, ultrasounds, plain X-ray images, nuclear medicine, and we try to diagnose diseases to guide the clinician on which way to go. Do we see pneumonia? Are we seeing cancers, broken bones, things of that sort, herniated discs in the back, so the patient can be treated. We also do certain procedures on patients. We'll do drainages, biopsies, lungs, livers, kidneys, bones, procedures like that. We also have radiologists who will do tumor ablations to treat cancers, arterial diseases. We take care of those sometimes as well also.
Hi, I'm Caitlin. This is Diagnostic Radiology. So in X-ray, what we do is we take pictures of the body. We see bones. We take pictures of abdomens and chest, so we see the heart and lungs, the intestines. This right here is where a lot of patients will stand for a lot of the X-rays. And right here is where our imaging receptor is. This is where the X-ray is captured. And so they'll stand here, and this right here is our X-ray tube, and this is where the X-ray basically shoots out of, and it captures the picture right there. And it can move all sorts of ways. It can move down. If they were on a table, we could shoot it there. And that is pretty much it for that. We also have fluoro, which my dear coworker Casey here will explain.
Hi, I'm Casey. So this is the other side of diagnostic radiology. So this is fluoroscopy. What we'll do here is we'll stand in the room with the doctor, and we'll wear these nice lead aprons here, and give the patient either some contrast to drink or another way. And the doctor will actually use this tube here to take x-rays of the contrast as it's moving through the patient's body.
My name is Darby. I'm the CAT scan tech here at the Imaging Center. I do CT here, which is computed tomography. You lay down on this table, you slide in and out a few times, and we just take pictures of your body, and it cuts slices like loaves of bread. We take all those images and reformat them to 3D images for our physicians. The typical kind of patients that get these scans are cancer patients, looking for anything abnormal in an x-ray, anything like that. We can do these scans with contrast or without contrast, depending on the physician and their request and what exactly we're looking for.
My name's Chris. I'm one of the MRI techs here at Ocean Springs. I've been in radiology about 20 years now. I work in MRI currently, and MRI stands for magnetic resonance imaging. It's a different type of exam that they use to diagnose patients, especially patients like pediatrics or cancer patients that don't need to receive a bunch of radiation. It's a very detailed study. It takes much longer than, say, a CAT scan or an x-ray, though it's it's much more detailed imaging compared to those. Also, it's very noisy, and most people have problems with claustrophobia in it. It's a very confined space. It does take longer because the image quality is much higher, and we take multiple images versus as a CAT scan will use the computer to reconstruct images versus a true raw image like the MRI scanner takes.
Hi, my name's Monique and this is Mandy. We do mammograms here at the Ocean Springs Imaging Center. This is our mammogram equipment, and it has all kinds of features, I guess, that you can make it position. We also do biopsies. Mammograms are a screening tool for breast cancer. So most women have them done yearly. And then we also do diagnostic workups. So once you have a mammogram, and if the radiologist sees something that is suspicious looking, they might call you back and have additional imaging done. And then from there, they decide if they want to do further look at, and that is a biopsy, or they can continue just following up on the patient. We also kind of do work side by side with ultrasound. Ultrasound helps us image the breast so we can properly work up patients.
Hi, my name is Cherie. This is Nina. We do diagnostic ultrasound for Ocean Springs Imaging Center. We do all sorts of ultrasounds. We do specialize in breast because this is a women's imaging. Mostly when a woman has her mammogram and they find a mass on her breast, we usually do an ultrasound to follow to find out if it's a cyst, which is fluid filled, or if it's solid, and then we'll go from there, whatever kind of treatment the patient needs. Usually a biopsy to find out specifically what it is, or and hopefully it's nothing, and we can just let the patient go.
We also do abdomens and pelvises, prostates and testicles. We do just about any kind of small part and body, vascular, anything that doesn't include the stomach, intestines, or any kind of bones. We can just about see in the body.
Hello, welcome to the Skilled Nursing Facility. My name is Rachel Ward and I'm the nurse manager here at Singing River Hospital. We are a 36-bed skilled nursing facility, and we have 36 private rooms, private bathrooms with 24-hour nursing care for patients. The majority of our patients are the elderly population, usually late 50s up to 100. They come here for various diagnoses, ortho, maybe hip fracture, knee replacements, maybe they have respiratory illnesses that's exacerbated, CHF, COPD, and they are just not ready to go home from the hospital. So instead of having to go into a nursing home setting or the family hire help 24 hours a day, they come to our unit and receive therapy 6 to 7 days a week, and then nursing care around the clock. We provide all the meals, all the medications, physician visits, nurse practitioner visits, consults, anything that they may need during the duration of their stay. We take care of their follow-up appointments, home equipment, home health, hospice if appropriate, bridging that gap between the hospital to the skilled unit and then to home or wherever their long-term placement may be. A lot of our patients have family members that like to stay with them around the clock, and that's completely acceptable. They have church groups that come in. We have group activities, crafts, paintings, musics, different things like that to try and give them a feel. Wi-Fi, they like to bring their iPads and tablets, just things to keep them busy. So the majority of our patients come here and stay for 20 days, up to 2 or 3 months, depending on their insurance or their diagnosis and how much assistance they require, until they're safe to go home or to a nursing home setting if that's more appropriate. This field of work is very rewarding, as we get to see a lot of patients graduate from the hospital setting back to home where they came from, where they can be safe and continue with their quality of life. we get to be a part of that, to be a part of their graduating from the hospital to rehab and then back to home. So it's a very rewarding career field.
I'm going to hand you your knife. Okay. Then what you'll do is you'll help her. You're going to hold the skin back here, and you'll have some suction if you need it. But you would make an incision in the skin, and then you'd hand me that knife, and I would give you a smaller knife, and you would make a little tiny stroke incisions into the uterus. And once you got a little peephole, then you would put the knife away. You would take your 2 fingers, and you would open up the uterus. All right, and then you would reach your hand in here and get hold of that baby's head. And now you are going to suction out the nose and the mouth. All right, you're going to pull that on out. So if our cord, it is attached, good. So you're going to clamp that cord a couple places, fairly 2 or 3 inches. So push and pull. Push.
The baby's not going to make it.
These babies are pretty resilient now.
Doctor's not going to make it.
There you go. Yep.
Good.
Yep. Then we're going to take some scissors and cut, and then we'll have the cord loose from the baby. You can tighten all that down. You can hand that to the baby nurse, and he can take care of her from there.
That's right. That's my job.
Yeah. So then after that, you would take out the placenta because it's no longer needed, not attached. We would bring the uterus outside of the body, suture it shut, put it back inside the body, and then close the skin. And that's sort of the basics. There's a lot more that happens. There's an anesthesiologist, a nurse anesthetist, a scrub, a circulator, an assistant, 2 people for the baby, a baby nurse and a baby doctor, or a respiratory therapist or a second nurse to do all of that. So there are 7 of us in the room, plus the patient and then your family. So it's quite a crowd.